Thank you for joining the 2017 showcase of T2 Biosystems. We're very happy to have you here. My name is Rahul Danda, Senior Vice President of Corporate Development at I'm happy to have with us today both Jonathan Edwards from Huntsville Hospital and Tom Kirn from Rutgers University and Medical School. Today they're going to talk about managing sepsis in the golden hour, controlling costs and improving cares through diagnostic testing. They'll be talking about a number of different ways to manage the septic patient from Jonathan's perspective, which is the pharmacy and stewardship, to Tom's in the clinical microbiology lab. Jonathan is the pharmaceutical lead of their Antimicrobial Stewardship program at Huntsville Hospital. He's also board certified in pharmacotherapy with added qualifications in infectious diseases, as well as board certified in geriatric pharmacy. Tom Kirn is the director of infectious disease diagnostic at Rutgers. He's also the medical director of the clinical microbiology lab at Robert Woods Johnson Hospital, and the medical director of New Jersey Public Health Lab and the New Jersey HIV Initiative. So thank you for joining us. Welcome our speakers, and we will begin with Jonathan Edwards. Thank you.
All right, thank you for that nice introduction. Excited to be here. First time as an adult in New Orleans. So I have seen a lot of things. A lot of things, kind of like one of those things, once you've seen them, you can't unsee them. And so coming from a small town in Tennessee of a population of about 1,000, you can imagine the shock when I got here that I experienced. So we're here to talk about T2 Biosystems, and what I'm going to focus on is primarily stewardship. And so when we talk about stewardship, we see a lot of information out there about antibacterial stewardship. We don't see a lot about antifungal stewardship. It's really in its infancy. And so we brought in T2 to our facility to try to promote the initiative of antifungal stewardship. So that's kind of the course that we're going to take through this presentation. T2 Biosystems did provide travel support for me to be here, and as well as honorarium to speak for you. So those are my only relevant disclosures. So just to give you a little bit of background about Huntsville Hospital, so it is a rather large community hospital. We're licensed for 941 beds. We have 10 ICUs. We have a rather large physician staff, over 800 clinicians, as well as 600 allied health professionals, and then we have about 200 members in our pharmacy team. We are a teaching facility. We're associated with UAB Medicine out of Birmingham. We are one of the busiest hospitals as far as emergency department visits go in the state, as well as a level 1 trauma center for North Alabama and Southern Tennessee. So just kind of give you an idea of the scope of the hospital where I'm at. So as we said before, antibacterial stewardship has been something that we've seen a lot of. We've seen it primarily in Joint Commission recommendations as far as CMS as well, starting to come out with more and more standards regarding this. And we know that whenever antimicrobial therapy is withheld from the septic patient, we know that each hour counts as far as mortality goes. But a little bit lesser known is fungal stewardship. So in this study, we saw a statistically significant increase in mortality when appropriate antifungal therapy was withheld from these patients. So definitely very important, however, probably not getting the play that it kind of deserves as of right now, because everyone's really focused in on antibacterial stewardship. So now you get asked the question, why T2? Why T2 at Huntsville Hospital? So primarily we were concerned with our Candida infections. Like we said, stewardship with fungal infections is kind of in its infancy. And so we don't have a lot of good diagnostics out there to help us out with stewardship initiatives. Most of our tests take, as long as a week to come back. So just really kind of ties our hands in order to be able to provide appropriate antifungal therapy. So we know that from the CDC that candidemia is the 4th most common cause of hospital-acquired bloodstream infections and is accounting for 40% of mortality. So something that we see relatively common in our facility. Also, blood cultures fail to identify 50% of the isolates. So we know that we're missing those people. So if we saw, as we saw on the previous slide, that 24 hours makes a difference, then how so would never even knowing that the patient actually had a fungal infection until potentially upon autopsy? I mean, there's going to be significant play into that mortality. And as well as, like we said before, it could take up to a week to get the results back from your micro lab, if you even get any back. As we all know, it's very difficult to get fungal isolates to grow in the lab. So then we wanted to say, okay, well, why T2? Why bring T2 into Huntsville Hospital? So the factors that led to our decision are that that we could detect the 5 most common human pathogens of the Candida species. We can detect them within 3 to 5 hours, again, greatly reducing that time of identification. Again, we've got sensitivity of 91%, specificity of 99%. And where have we seen with blood cultures, we only get about 50%. So we're going to be highly sensitive and specific for that disease state. Limits of detection all the way down to 1 CFU per mil. So we know that if we were to culture that specimen with just that one colony in there, the likelihood that we were actually going to grow it, very, very minute. But with this test, we can actually pick it up all the way down to that level. Then also, T2 helps direct and guide therapy, and that's going to be huge with the sepsis initiative, as we've seen with the core measures that have come out from CMS. But also another thing that it's going to drive is antifungal stewardship as well. So in our facility, we rolled this out in basically 2 phases. The first phase, we wanted to make sure that we had the clinicians, had the access to this drug that would be most appropriate or most beneficial. So we've started off with infectious disease physicians and oncologists being the only physicians that can utilize this test in our facility. We also further delineated a criteria for use, which included febrile neutropenic patients without observed cause. So we know those patients are at high risk for fungal infections, as well as patients who have ICU stays of at least 72 hours with central venous lines, unexplained fever, on broad-spectrum antibiotics, and one of the following that you see there. So what our thought process was here is that patients weren't responding to antibacterial therapy within 72 hours, so we had to look for other sources. So of course, one of those sources would then be potentially fungal. And then lastly, central venous line and unexplained fever and sepsis. So these are the criteria that we built in addition to the restriction for the provider, in order to make sure that we've got a good handle on T2, make sure that we understand how to utilize it and put it in the hands of those prescribers and in those patients that are going to be most benefited from this process. Then also there's going to be a second phase of where we're actually going to release this product out to our surgeons as well as our intensivists, and that's based on the results that we're going to talk about today. So anytime that you implement a new process, you always have to measure something. So what we wanted to measure was our medication use. So how did T2 affect it? Did it increase our utilization of medications, decrease it, or did it remain relatively the same? Did we see a change in class? So did we move from more echinocandins to using more azoles? Next, we wanted to look at patient characteristics and risk factors. So were we adhering to our criteria? Were we using this test in the most the sickest patients that would really benefit from this process? The T2 Candida panel results. We wanted to see what was the results. Like we said before, with stewardship, we really didn't have a lot of data as far as our fungal isolates go. You know, what was in our facility, and then also we wanted to see time-wise, you know, how did time affect it? How rapidly that we're able to identify these organisms now. Then corresponding blood culture. So we wanted to look and do our own sensitivity and specificity analysis to see if what we saw in the studies is what we see in clinical practice. You know, sometimes those can vary with medications, which I'm the most familiar with. And so we just wanted to just check and see, you know, did we really see the benefit that we saw in the studies? And then time to de-escalation. So if we can identify these patients within 3 to 5 hours, as opposed to waiting, you know, up to a week, you know, we expected that our de-escalation of therapy would be much rapid. And then duration of therapy. So if we were able to stop therapy or de-escalate therapy, and then you would also see a reduction in your days of therapy for your echinocandin use and your azole, which then would correlate to beneficial effects on your pharmacy budget as well. So what we expected to see is reductions in unnecessary antifungal therapy. So whenever you do have that patient that's not responding to antimicrobial therapy within 72 hours, and you're just kind of grasping at straws to try to figure out, exactly what is going on with this patient. So if we could rule out a fungal cause within the first day, that's going to be a huge benefit to the patient. Because as you know, after the patient is exposed to that first dose, just one dose of echinocandin, it's going to increase their likelihood that they're going to have a resistant organism in the future. Then we wanted to see if we could improve our time to appropriate therapy. So as the results came in faster, and then we thought, well, we could de-escalate therapy faster, or even completely remove therapy if we found that antifungal therapy was not necessary. And then lastly, we feel that we would probably decrease mortality as we would be able to identify these patients quicker. And as we saw in the study that I mentioned at the very beginning of the talk, we can initiate therapy faster, and then the likelihood of mortality is going to decrease. So we presented our results at ASHP this past December. And the rest of this talk, I'm going to go through the results that we found and let you know how that we partnered with T2 in order to implement a fungal stewardship program in our facility. So first off, we want to look at what did the T2 Canada results tell us. And so we found that about 9% of the 345 patients that we included had a positive result. So remember that this positive result was provided to us within 3 to 5 hours, as opposed again to waiting a week to try to figure out what these patients were infected with. And then we broke out further those positive results into what were the organisms. So we found that the majority at 47% were Candida albicans and tropicalis, which is what we would expect to see. Next, at 41%, we saw parapsilosis, and then thankfully, at only 12%, we saw Crucei and glabrata. So this is something that we kind of thought that we would experience, but wasn't 100% for sure. So this helped us out with our stewardship program to know what organisms are commonly found in our facility. So next, we wanted to find out what impact did those negative results have on our patients. So we had 311 patients that were evaluated, and 41% of those therapy was actually not even initiated. So our facility, our clinicians felt like that this test result was fast enough to where that we could actually test the patient to see if they had a fungal isolate that could be identified by T2 even before starting therapy. So this was a huge benefit to not exposing those patients, because with any medication, there's always a chance of side effects, adverse events, and then also issues with resistance as well. So that was huge, and as well from the pharmacy budget perspective. Not initiating therapy means those are drugs that you're not paying for. And then therapy was discontinued in 23% of the patients. So once it was identified that the T2 test was negative, we were actually able to contact the prescriber and stop therapy. And then in 36% of the patients, we found that therapy was continued. The primary reason that we found for therapy continuation was that typically these patients were not doing well. So it's very difficult for a physician to actually de-escalate therapy whenever a patient is not doing well clinically. So out of the 311 patients that we saw, 64% or 200 patients were actually affected by a negative T2 result. So next, we wanted to evaluate. So we found in the studies that we had high sensitivity and specificity, much better than what we found with blood cultures, and actually FDA approved a superiority label for T2 over blood cultures. So we wanted to see in our facility, we see the same thing. And so on the left-hand side, you'll see blood cultures. Blood cultures were positive and then were confirmed by T2 in 10 patient cases. Blood cultures were negative, however, were T2 positive in 26. So these are patients that we would have missed. So had we not have access to this technology, we can't say for sure what would happen with these patients. The theory is though that they would have had a more negative outcome than what they did. So that led to a sensitivity of blood cultures of almost 30%. So before we previously mentioned 50%, so we actually saw a little bit less in our facility. Now we compare that to T2. T2 positive and then confirmed by blood cultures was 34 patients, but T2 negative but confirmed by blood cultures, we found 2. So that made the sensitivity of T2 be 94%, which was slightly higher than what I showed you in the previous slide, with specificity of 100%. So the take-home message here is that we would have missed those 26 patients, and then this is reinforcing the superiority claim of T2 over blood cultures for the identification of Candida in these patients. So then we wanted to identify what units would highly benefit from the use of T2, because we wanted to make sure that we weren't limiting T2 down so far that we were missing patients that wouldn't benefit from, or that could potentially benefit from T2. So we found that we looked at our positive cases first, the 34 cases that we had, and we found that primarily we saw in the ICU, and we had 60% of those isolates were located there. So this is kind of what we expected. It was one of our criteria. And so this kind of made us think, well, maybe moving forward, we might need to expand out our program to include intensivists as well, or pulmonologists that we utilize in our facility. The next thing that we noticed was we broke it down further into units. And so we saw that our SICU, or our surgical intensive care unit, had more than our medical intensive care, which is not something that we had anticipated. So this led to us considering the fact to open T2 up to our trauma surgeons as well as our general surgeons as well. Whenever we look at how T2 performed on the floor, not a surprise, we saw our biggest impact with our oncology group at 43%. So the next thing we wanted to look at was there any difference whenever we looked at those 26 patients that we would have missed? And so we found very similar results. Majority of these patients were located in the ICU. Again, majority of them being in the SICU, again, reaffirming that we need to open up our grouping to our surgeons. And then on the floor, again, very similar results to what we found with the positive test, with oncology leading the way. Again, confirming that since we did include oncologists as a physician group that could order the test, just confirming that was an appropriate physician set that needed to have access to this test. So T2 candidate infections, we're able to identify the blood cultures much faster than what we were seeing before. And then just kind of wrap up this slide is that we saw the majority of the biggest impact that we could see was in the ICU, but we also saw some significant impact on our oncology floor as well. So the lessons that we've learned through T2 is that there was kind of a void between the microbiology and our physicians. Microbiology is excellent at doing benchtop work, getting us the resources that we need, the tests that we need, but applying that clinically can sometimes be challenging for the microbiologists. And then as far as the physicians go, they're very good at diagnosing and managing patients, but sometimes the diagnostic tests, they're coming out so quickly, it's kind of hard to keep up with them. So we found a niche for pharmacy, and basically the bridge that we built was antifungal stewardship. And so being able to identify whenever a test is positive and then notify the physician quickly is kind of the place where we came into therapy, and then also recommending therapy as far as de-escalation and also discontinuation when appropriate. With T2, it's very simple results. It's not like what you would see with procalcitonin or with lactic acid, where that a lot of things can impact it. With T2 being so sensitive and specific, there are not a lot of things out there that are going to interact with this test to give you a false positive. And the results are simple. It's a yes-no test. Whereas with procalcitonin, you have to measure serial levels and make sure that you're falling at a certain rate. And so it can get a little bit complicated for clinicians to understand, to make sure that those are ordered and then understand what to do with those results. So very simple. What we did at Huntsville is that empiric antifungal therapy could be discontinued if the T2 test was negative. So I would initiate a call to the physician to get that therapy discontinued. If the patient was not on empiric antifungal therapy, but T2 was positive, we actually had a pharmacy and therapeutics approval that the pharmacist could actually initiate antifungal therapy per protocol for those physicians and then notify the ID physician immediately after initiation of therapy. So whenever you utilize this test and you take the test results and then you guide therapy based off of that, guess what? You're doing antifungal stewardship. And so that's how that we partnered with T2 in order to actually initiate our stewardship program with antifungal therapy, just because the diagnostics just weren't there yet for us. We were focusing heavily on bacteria, but with a test that makes it so simple, a yes-no answer, so quick to come back within 3 to 5 hours, and very sensitive and specific, it made it very, very simple for us to get that program up and running. So just to summarize what we talked about today, so T2 Canada provides superior results compared to blood culture. So in our study, we found 94% versus 28%. The T2 Canada provides actionable items within 3 to 5 hours, as opposed to waiting, up to a week. And then even though if you were to wait up to a week, there's a potential that you wouldn't have growth in that plate, or that you can even identify that organism, as we saw with the 26 isolates that we actually missed. And then T2 Canada negative results can decrease your utilization of of echinocandins as well as azole antifungals in those patients that you can rapidly de-escalate therapy as opposed to waiting for 7 days to find out if those cultures are negative or not. T2 Candida improves hospital economics through de-escalation. So as you know, with a de-escalation of therapy, typically you de-escalate to a more narrow spectrum and less expensive agent, as well as non-initiation of a necessary antifungal therapy. So if there is a suspicion of fungal isolate present, however, with the test being so rapid that we were actually to show that 41% of our cases we didn't even have to start antifungal therapy in because the clinicians felt confident that they can get those results back fast enough. And then anticipated additional benefits that we're going to see as we include more physicians into our group as able to order T2, as well as potentially the forthcoming bacterial panel that T2 is working on right now, would have a huge benefit. We've seen a significant impact on our fungal isolates, but whenever you move to bacteria, that's going to be just exponentially increased. And then just a very nice shout out to T2 Biosystems for acting as a very good partner with us. And so so getting that education out there, anytime that you can tap into resources that a company has, it takes more work off of you. So being a single pharmacist attempting to take on the world of stewardship is very helpful whenever you have a partner that can go out there into the community and talk with these physicians, talk with your staff on how T2 can be initiated, how that it works, the clinical data behind it, as well as providing them with the resource from us to say, this is the place where that we feel like in our facility that would be the best use of this test. So a huge help from them to get us started. So with that, I will pass it off to our next speaker. Thank you.
Okay, good afternoon, folks. So I'm from New Jersey. I didn't see anything here that I haven't seen before. So I'm going to tell you a little bit. I appreciate going second here because you've already heard a lot of the expected clinical impacts of this diagnostic technology, so I'm not going to reiterate them, but I'm going to tell you about our experience using the T2 Candida system at our academic medical center. So our hospital is the main teaching hospital of Rutgers Robert Wood Johnson Medical School. We have about 750 beds. It's a level 1 trauma center. We have a large bone marrow transplant program, renal transplant, heart and lung transplant, multiple ICUs and MICUs. And I'm going to tell you about how we implemented it there. There are some differences to what we've already heard, and I think I actually learned some things from the last talk, and so I think some of those key differences are interesting to consider. I always like, actually I have to tell you about my disclosures, so there they are, including T2. I always like to start with this slide. So normally when I give a talk on rapid diagnostics in infectious diseases, I talk about how we're narrowing the gap between when a specimen is drawn and when you can actually give definitive therapy to patients with bloodstream infection. And I get to this slide and I say we're getting towards the Holy Grail. And the Holy Grail is taking a blood specimen from a patient, directly putting it in some black box, and getting an answer in a very short period of time about what the organism, what the etiology is, and what it's susceptible to. And we're getting closer, and this is an example of one of those tests that gives us even closer. And I think the interesting thing about the Candida assay is that, it detects 5 species of Candida, and I'll talk more about that in a few minutes. And they typically have very predictable susceptibility patterns. So not having susceptibility data right when the organism is detected is not as critical for Candida as it might be for Klebsiella, for example. So we'll talk a little bit about that later. But anyway, so in 2016, we started laying the groundwork for bringing in the T2 system and had multiple meetings with our C-suite folks, including our VP and operations folks. And we presented a very simple PowerPoint to them in a kind of describing the clinical problem in lay terms. So with bulleted facts, many of the things that we've just heard about, the mortality associated with fungemia and its significance, how patients have prolonged length of stay when they don't get adequate therapy or when they just have a candidemia in and of itself, and then the potential value of earlier diagnosis and earlier treatment. And we provided our data on the number of candidemias that we annually see. So even at our place where we have lots of transplant, we have lots of trauma, we identify by culture about 60 patients with fungemia caused by Candida a year. We expect that probably, based on data that's been published, the sensitivity of culture is about 50 to 60%. So we would expect to see twice as many implementing a technology that is higher sensitivity. And so we talked about that as well. We showed photos of the instrument. So our VP is really into technology, and he liked seeing it, and told him about how it worked and the novel technology with detection. And then we emphasized that this was one of the first direct from blood tests that's gotten FDA cleared for identifying bloodstream pathogens. We showed the published data from the FDA pivotal trial demonstrating high sensitivity and high negative predictive value. And we pointed out, based on that negative predictive value, that could have profound implications for our pharmacy budget and suggested potential savings in that area. T2 has a very nice economic modeling software program or spreadsheet that you can use, and we presented some of that. We basically took their estimate on savings and divided it by about 8, and we didn't want to be overly optimistic. But we did suggest that there would be savings associated with this. But we then also pointed out on balance that this is a test that's done in addition to standard blood culture techniques. So there is some cost associated with it. There's been limited published data so far, and this was now in 2016, so this was about a year and a half ago. There's more now. And it's really was going to be uncertain to the value of this technology in our setting. And our recommendation was, let's give it a try and measure the outcomes to see what happens. Now, so in consultation actually with the folks from T2 and all the stakeholders on our side, we came up with this algorithm, which is very similar to the one that we've just discussed. So basically on this side, patients for whom antifungal is being considered. So this might be a patient that is admitted to the SICU who has had an intra-abdominal surgery and may not be defervescing on antibiotics or may not be getting better on antibiotics. We would have them order a T2 Candida test. If it's positive, obviously they would start the appropriate antifungal. And if it was negative, they may consider withholding antifungal therapy. The SICU is one of our largest users of empiric antifungal therapy, second only to the bone marrow transplant unit. So they are very quick to pull the trigger on empiric antifungals when they suspect that these patients have invasive candidiasis. On the other hand, those patients for whom antifungal therapy has been started, we would recommend that they order a T2 Candida test. If it's positive, then obviously if it needs to be escalated to an echinocandin from an azole, for example, they would do that. If it were negative, well, we didn't say stop necessarily, but we said you could think about stopping or you could continue your current empiric regimen. And the reason we were soft on that was because when we talked to the oncologists in the bone marrow transplant unit, there was no way that they were going to stop antifungals based on a negative T2 test because their level of suspicion for infection is so high that just wasn't going to happen. But the key is that in the face of a patient that wasn't doing better, the hope was that they wouldn't escalate them to the next level. So they might not keep them on an azole and not go to an echinocandin. So that was kind of the reasoning behind our algorithms here. And much like what we've heard previously, we wanted to really target those populations with a higher pretest probability and those populations that would benefit the most from rapid de-escalation and rapid escalation. So we included our MICUs, our 6 CCU, our 3 SICUs, and our bone marrow transplant unit, our leukemia lymphoma nursing units, our solid organ transplant units, and our PICUs and pediatric hemonc nursing unit. And we allowed any physician with a patient on any of these locations to order the test. And we actually encouraged that. So when we did our education, we said, here's a brand new test. This is what it's used for. Please consider using it according to the algorithm that we've provided. We also allowed ID physicians to order it anywhere in the hospital. So when we look back at our data on those 60 cases of fungemia from the year prior, not all of them were in these units. And in fact, about 20 of them, so a third of them, were in other units, so kind of scattered throughout the hospital. So we did say, if you get an ID consultation and the ID consultant decides that the pretest probability warrants testing, we allow them to do that anywhere. Now, the reporting, as we heard at the end of the last talk, is really critical here. And the way that we report these is we call our routine is to call positive blood culture results to the patient's nurse. So in this case, if we have a positive T2 test, it gets called back to the nursing station, just as any other positive blood culture result will be called. In addition to that, all positives and negatives are reported to our Antimicrobial Stewardship team, which consists of myself, multiple ID physicians, and pharmacists who take turns being on call. And those folks, between hours of 8 a.m. and 5 p.m., we're not funded to be staffed 24 hours a day, unfortunately, will then call the attending physician and make recommendations that we had agreed upon. And they would be de-escalation or escalation, depending on the result. On the evenings, weekends, and holidays, where there's no stewardship coverage, and these are practical things that everybody has to deal with. Not all hospitals necessarily have 24-hour stewardship coverage. So on evenings, weekends, and holidays, the stewardship team was emailed, and they would follow up on it in the shortest time period that they could. I already mentioned the types of reports that come out. So either the test result is negative for the 5 Candida species targeted. It could be positive for albicans/tropicalis, and in that case, we would recommend fluconazole. If it's positive for Candida parapsilosis, we strongly recommend an azole. And if it's cruziatic labrata, we recommend using micafungin in our hospital, which is the kind of candida that we have on our formulary. So here's some data so far. The uptake was relatively slow in the beginning. People forgot about the test, didn't think about ordering the test, and we had repeated rounds of education that kind of helped us get more patients enrolled. But up till March 2017, we had 98 test results, about the same positivity rate as we heard about from the last talk. So 8.2% and 91.8% negative. And I'll just highlight a few interesting results that we saw. We had 2 patients with a T2 Candida that was positive for parapsilosis, but negative blood cultures. One of those patients had necrotizing fasciitis. The other one had recurrent AML and neutropenia. We had 2 blood cultures that were yeast positive by blood culture. We had blood cultures that were positive for yeast, but the T2 Candida was negative, which made us a little nervous until we found out that these were off-panel organisms. And so we would expect that result. We had 1 patient with yeast in a blood culture, and that patient didn't get a T2 at the time that they got our initial blood cultures drawn. But the interesting thing was they did get a T2 the next day, which was negative, along with a repeat blood culture that was negative. The patient had been on therapy and the PICC line was removed, so I think we can explain that one pretty easily. We actually had one of these other positives was a patient who had a blood culture drawn on day 1. The blood culture went positive for yeast on the gram stain the next day. They then, they knew what this technology could do, so they ordered a T2, and they had the ID from the T2 before they had the ID from the blood culture that was already positive. So that was kind of an interesting use of the technology. And these are a summary of the results from the negative patients. So of the 90 total negative results, 50 of them were not started on antifungals. So these are, again, in these high incidence areas where antifungals are commonly prescribed empirically, they actually didn't prescribe antifungals before getting the test result, and they didn't start them after the negative test. 40 of them were on antifungals, and you can see what the distribution of antifungals are here. And of those that were on antifungals, 10 patients were de-escalated to no antifungals after the negative result, with a median time to stop empiric therapy of 3 days. Some of the reasons for continuing on antifungals was patients were BMT patients, or they had hematologic malignancy, and they were on long-term prophylaxis, and they were probably going to be on long-term prophylaxis anyway. They had severe sepsis, so they were particularly ill, and we already heard about the issues with de-escalating in those patients. And then a few other unique situations. We had the patient we had the 2 patients with the non-panel organisms in their blood. We had a patient that had a Candida parapsilosis cultured from a medical device in the absence of a T2 positive result. And then we had a negative T2, but previously positive blood cultures for C. albicans and C. glabrata. And they were both on antifungal therapy at the time of the test. So their assumption was that the T2 was negative because the patient had been on therapy, but deserves therapy because the blood culture was positive before that. So just in summarizing some of this result, the negative T2 Candida results led to cessation or no initiation of antifungal therapy in 67% of the patients out of these 100 and so patients. Most patients were evaluated in the SICU, which is our highest user of empiric antifungal. And if we look just at those SICU patients, where we're very, very commonly starting them on empiric antifungals, they were held in 52% of patients that had a T2 negative. Now, ideally, we would have a control group here, and identifying a control group is quite difficult. We're working on that now to kind of have a retrospective control group. But just given the fact that we identify significant reduction in antifungal use in patients that are typically exposed to lots of antifungals, I think is very interesting. The limitation of our analysis, however, was the inclusion of the hematologic malignancy patients on prolonged prophylaxis. There are patients that we're never going to get off to antifungals anyway. So I think that they give us a difficult baseline to start from. So in further analysis, I think we might target those where we can actually have a significant impact. We do not need to identify a control group for comparison, and we are completing data collection. We've submitted some of this data for a poster at ID Week in October. And so in conclusion, we saw that a negative T2 Candida test did affect empirical use of antifungal therapy in certain patient populations more so than others, and may be useful in controlling the overuse of antifungals. In just the last couple minutes, I want to talk about the next tests coming down the pike here, and we are participating in the T2 bacterial pivotal study with the expectation of enrolling about 1,800 patient samples in a multi-center design. We expect to see value outside of those patient populations that we've targeted with T2 Candida to include potentially the emergency room and ICUs and other patients being tested by blood culture. So this is the panel coverage for the T2 bacteria test. And it functions very similarly to the T2 Candida test as far as technology goes and turnaround times. The LODs are a little bit different than the Candida test, so they vary from 1 CFU per ml to 8 CFUs per ml in seeded studies, but still, quite impressive limits of detection. And these organisms that are covered, I guess the escape organisms, represent about 70% of bloodstream pathogens. Bacterial bloodstream pathogens. And the thought is that once this gets FDA cleared and we can put it into clinical practice, it'll allow us to detect very rapidly that 40% or so of organisms that require escalation or are not typically covered in a usual empiric regimen. So we'll identify these early and quickly, allowing us to escalate appropriately in those situations and provide empiric coverage or early coverage for about 95% of patients as opposed to the 60% that we're currently covering adequately. And we've had a couple of, do I have another minute or two? Okay. We had a couple of interesting observations so far due to, as a consequence of participating in the T2 bacteria study. We had a elderly male patient who was on hemodialysis. He had been in the hospital recently with VRE bacteremia and treated for it. He finished his therapy. He came back in. He developed fevers to 102 during and became hypotensive during hemodialysis. He was admitted directly through the ED. He was seen by ID prior to his antibiotics. He got 2 sets of blood cultures drawn, and we consented him for the T2 bacteria study at the same time. His T2 bacteria assay was positive for Kleb pneumo. His blood cultures were negative, including terminal subcultures after 5 days. In our opinion, this appeared to be real sepsis and could be consistent with a gram-negative sepsis. So I think this is a case where the T2 instrument detected something that blood culture did not. In another case, a patient with ephesium bacteremia who had 2 out of 2 sets of blood cultures that were positive and urine cultures positive that was on therapy. They repeated the blood cultures the next day when he got consented for the T2 study, and the blood cultures the next day were negative, but the T2 bacteria test was positive. Again, this likely represents a true positive on the T2 and a false negative blood culture. And then finally, we had just an interesting case, 2 sets of blood cultures drawn from a febrile patient with suspected bloodstream infection that got consented over the weekend for the T2 study. We run the T2 study instrument only during weekdays. So the tech came in the next day and ran the T2 bacterial assay, and it was positive for Staph aureus. This was on Monday. And we went to look in the chart to see if the blood cultures were positive. They were still negative. They turned positive later in the day and grew Staph aureus. So even with a work stream that's basically investigational in design, we were still able to identify an organism from this patient earlier than the blood cultures that we're using for routine standard of care. So the next steps, what are we doing next? We're going to implement T2 Candida testing in a standard blood culture order set. So we really think that we're seeing big impacts in our SICU. And so we're trying to implement a process by which the first set of blood cultures, physicians can't tell the difference between bacteremia and fungemia. with a patient in the SICU. So what we'd like to do is, for our first set of blood cultures, have reflexively and compulsory T2 candida test done at the same time. So this way we have that data right at the onset before they get put on therapy. So we're trying to make a reflex order. When you order a blood culture set, first time from a patient in the SICU, it automatically orders a T2 candida test. We're maintaining T2 candida in our antifungal stewardship protocols. We're trying to combine results with quality processes at the hospital to ensure that we have rapid and effective use. And we're going to finish out the T2 bacteria pivotal trial. So with that, I'll thank you for your attention, and I think we'll take a couple of questions. Thank you. Yeah, if you have a question, please come to the mic. Thank you.
Yeah, really interesting presentation. Basically, I come from the University of Rome Tor Vergata, and we have had an experience with the T2 Candida. Actually, in different slides, you specified that there are 5 results, which are Candida glabrata, albigans, etc. In our experience with the 2 Candida, all the results were basically 3, which were Candida albigans tropicalis, Candida krusei glabrata, and Candida parapsilosis. So my question is, how can I understand if my patient has Candida albigans or Candida tropicalis? Because it's very important for a microbiologist to know this, considering the antifungal stewardship and also considering the EUCAST and CLSI criteria that needs to be applied for a specific therapy. Because basically the results are 3, right?
Yeah, that's correct. So Candida tropicalis and albicans are grouped together. Candida glabrata and krusei are grouped together. And Candida parapsilosis is a single result. And then the 4th result is no Candida detected. And the reason that they're grouped that way is because of their common antibiograms. So our recommendation, based on susceptibility results from krusei and glabrata and the likelihood that they're going to be azole resistant, or the possibility that they're azole resistant, is that we start in echinocandin. If it's an albicans, if it's a parapsilosis or a tropicalis, we usually recommend an azole.
Okay. But do you agree that, like, effectively, when I see these results, also when we were expected for that, for 5 species was a little bit a problem for us, because actually we were forced also to specify the microorganism also for epidemiologic reason.
Yes.
So we were forced still to grow in a specific culture media and make sepsis either extraction or...
Yeah, I see that. Yeah, it could be an issue with reporting and understanding the local epidemiology of those organisms in your hospital. But
thank you very much.
Yep, sure.
Diane Halstead, Jacksonville, Florida. And I was wondering if you thought it would be reasonable to perform a procalcitonin, since that detects bacterial, that could act as a screen as to which patients to select for the T2.
You want me to talk about that, or you want to talk about? I have some comments about that. But
I probably wouldn't be the best person to answer that question because I absolutely hate procalcitonin. So there was, I don't know if y'all saw the Moses trial recently came out. That was a very interesting trial that showed that 80%, if you had an 80% decrease in procalcitonin, you had a likelihood that you were going to decrease your mortality. So that was really good. That's really great. But from a stewardship perspective, it told me nothing. So we looked at, from a stewardship perspective, if you're not getting in that 80% reduction that we saw in the Moses trial, and then they looked to see, well, if you escalated therapy or changed therapy or did something different, would that adjust your procalcitonin, like make it fall faster so that you could identify if that patient was responding to therapy, and it had no change on it. So it really hasn't helped us much. Some of the guidelines that have come out, have said, probably not good for initiation of therapy, but might be good for de-escalation of therapy, specifically in pneumonia. But I think the jury's still out on sepsis. So sorry, that's my bias for you.
Okay. But you wouldn't use it as a screen if the procalcitonin is negative, that those would be the patients you test by the T2 for fluid effect.
No.
Okay, you both. do
Yeah,
not
no,
like
I'm also not a big procalcitonin fan, but
I was afraid.
I think with regard to initiation of therapy, that's really shaky ground at this point. Shaky footing there. So we've not considered implementing that as part of our algorithm for testing. Yeah.
One other question: are you considering including a generic candida in your test algorithm, other than the species that you normally detect? So that, for example, if it's positive, you'd know at least it's a candida, maybe not one of those.
Oh, you're asking the company that question. Yeah, I don't know if they've considered adding a generic candida probe to their assay or not.
That would help address that issue you brought up.
You might want to talk to some of the representatives from T2 afterwards about that. I see what you're saying. Yeah.
Okay, thank you.
All right. Thanks again for your attention. And if you have any other questions, feel free to catch us after the session.